Thank you very much. So, hello everyone. My name is Diana Bright, and I'm the Public Health Evaluation Lead for Digital Health at Public Health Wales. I'd like to begin by thanking Sabine for the invitation to speak as part of this seminar series, and it's a real pleasure to join you today. So, what I cover today is kind of setting the scene, like why digital health matters. And I'm going to talk about our national policy foundations in Wales and give you some examples so you have a bit of a background. Then I will talk you through digital inclusion as a foundation and where our evidence comes in, the work that we've been doing in Public Health Wales. And then I'm going to move on to insights from our work with the World Health Organization, but specific to the European region. We've been doing a few reports about digital health equity. And then I'm also going to talk to our role and on our ongoing work, and this includes the WHO Collaborating Center that has been, we have been designated a collaborating center in September. And also I'm going to just give you a brief overview of a project that I'm leading that has been funded by the NIHR, again in digital exclusion and health inequalities. So that is what I'm going to cover today. So first of all, why digital health equity matters is, well, we know that it is now a core part of modern health systems. We know that digital transformation brings major opportunities, from more personalized care, easier access to information, and new ways for people to interact with services. But obviously not everyone is able to benefit equally. So there are differences in access, skills, and confidence and trust. And that means that sometimes some people might find it harder than others. So without an equity focus, digital change can create new barriers. So it is very important to understand that equity considerations span both technical and social factors. And if we embed equity early, that means that we are supporting fairness, access, and usability for all. So this is like the background of what's happening in Wales. So with digital health now central to how people access care, equity becomes essential. So the Welsh government has already recognized this in its strategic vision. One of the clearest examples is A Healthier Wales. So this sets out the long-term plan for integrating digital innovation into a whole system approach to care. This was first published in 2018, but is now been updated last year. It outlines the Welsh Government's ambition for a preventative, person-centered, seamless health and social care system. This is the overarching policy direction that shapes our work in Public Health Wales. And crucially, the plan identifies digital and data central to modernizing services and improving outcomes. It describes digital as an essential enabler of better quality care, more consistent pathways, and greater citizen empowerment. But at the same time, it makes clear that equity must guide this transformation. So not everyone can or wants to use digital services, and face-to-face support remains essential. So by starting here, we can see that addressing digital health equity isn't a side issue. It's fundamental to achieving the national vision. And that's why today we are exploring this systems approach and that we've been following. So more clarity about how to achieve a healthier Wales came in 2023 with the publication of the Digital and Data Strategy for Health and Social Care in Wales. So this basically translates the principles of a healthier Wales into a concrete digital roadmap. So for example, the 6 missions and the digital transformation streams you see here are the key mechanisms Wales is now using to deliver that vision. So for example, there's a focus on stronger data, interoperable systems, digital inclusion, user-centered services, and a digital confident workforce. So this streams and missions. They are all interconnected components that need to work in alignment in order to reduce digital inequalities and support fair access to health and care for everyone in Wales. So this is just an example. The NHS Wales app is the most visible national digital health initiative. It was developed and supported by digital services for patients and the public within the Digital Health and Care Wales, which is like the special authority that develops and designs digital services. And by doing that, they ensure the service is nationally led, that is user-centered, and is integrated across the wider NHS Wales digital ecosystem. So the app replaces the older My Health Online, and the message is very clear: is give the people, record of care in the hands of patients. And at the moment, it's more administrative, but it is evolving very quickly. So it will be much more. It's not as mature as maybe the England version, but it's evolving very quickly. So another example is the electronic prescribing, which sits within the digital medicine transformation portfolio. That is also led by the Digital Health and Care Wales. It has two main components, which is the electronic prescription service in primary care and also the electronic prescribing and medicines administration in wards and hospitals. This work has been shaped by real user needs. So for example, they engage pharmacies, GPs, hospital clinicians, nurses, and patients to understand what isn't working and where the biggest opportunities for improvement are. So as you can imagine, medicines management is one of the most common interactions people have with the health system. So making this process digital and join up can reduce variation, reduce errors, and improve access. But one thing is very clear: this is only gonna work if people have access to it and use it. And well, digital equity is not about apps and platforms. It also includes how technology supports care, prevention, and independence at home. So this is another example. This was developed by Tech Combry. This brings together three core elements of remote and preventative care. So the first one is a video consultation, which proved vital during the pandemic, and it continues to support remote care. There's also the telecare option, which is, for example, pulse detectors and movement monitoring that help people remain safe at home and also enable early intervention if necessary. And the telehealth, which is remote health monitoring that supports people's health and well-being. So there's a few pilots going on, and there's also a national public survey that will help identify what works best and where the biggest opportunities are. So this is kind of the background of what Wales, as a nation is doing. So as I mentioned, digital health transformation only delivers equity if people can actually access and use digital services. And this brings us to one of the most important parts of the system, which is digital inclusion. So this slide shows the work that's been happening across Wales to shift from exclusion to inclusion. So programs like Digital Communities Wales help build digital confidence, skills and access across all communities. And at the same time, they set out national priorities, which include embedding digital inclusion in public services to implementing a new minimum digital living standard. And I don't know how many of you have heard of this minimum digital living standard, but I'm just going to give a brief overview of it, which is priority 5. So this is a very exciting thing that the Welsh government has done in collaboration with academic partners and the third sector organizations. It's a nationally developed standard defining the minimum digital access, equipment, skills, and support people need to participate fully in modern life. So as I said, it was developed, commissioned by the government, and it was informed by citizens and communities. This provides a framework for digital inclusion, supporting policy, practice, and future measurement. It has been integrated into Welsh Government's digital inclusion strategy, and is very relevant for our work in Public Health Wales because it sets out the wider digital inclusion conditions that shape whether people can access and benefit from digital services. So that's very important. And then I'm going to give you an overview of what we've been doing in Public Health Wales in terms of digital inclusion research and equity in digital health. And some of this work has been in collaboration with WHO Europe. So our work in Public Health Wales in terms of digital inclusion started before the pandemic. So there was a recognition that it was an issue that it was becoming greater and greater. So in 2018, Public Health Wales did a nationally representative household sample. It included over 1,200 individuals aged 16 years and older. What we found is that at the time, 13% of adults in Wales didn't have access at home, didn't have internet access at home. Overall, 66% use digital technology to support their health. We asked them about 10 different activities, whether it was managing appointments, tracking goals, supporting long health conditions, or seeking emotional support, for example. So when looking at only the people who have access to the internet, it increased to 75%. But this kind of make us realize that not everyone with access will actually engage with digital health, which I thought it was a very important finding. And when we break this down by population groups, the inequalities become clearer. So women were slightly more likely to engage than men. Younger people were far more likely, more active digitally than older adults, with engagement dropping from 85% in 16 to 29-year-olds to just 24% in those aged 70 years and over. We also see a strong deprivation gradient, which people in the most deprived areas far less likely to use digital tools for health than those in the least deprived. And perhaps the most important finding is that people in poorer health, so those with the greatest health needs, were less likely to use digital technologies to support their health. So even when access is available, engagement is unequal. And this is crucial insight for digital health, because the very people who might benefit from digital support are often the least likely to use it. So in the same survey, there were questions about social media use and health. And Twitter still was called Twitter. So 77% of West population use one or more social media platforms to manage their health or find health information. Then reported sharing personal details about their health on social media. And the differences of use between demographics is that we found that higher use of social media among women and younger age groups. There was no difference by deprivation. And in terms of health, it was the same as the other results: lower use of social media among those with poor self-reported general health, and those who reported more health-harming behaviors like smoking, alcohol, or poor nutrition were more likely to not use social media. So obviously the pandemic happened, and then digital exclusion became even a greater problem because everything had to be accelerated so much for people to have access to services. So we wanted to know how, how people were using digital health to support their health, and what were the future preferences. So this time our survey included 2,400 adults as well, the same 16 years and older. So there was no evidence that the pandemic increased internet access, which we were very surprised. So fewer than 1% reported newly gaining access. Younger people and those with long-term medical conditions were most likely to use digital tools frequently for health-related activities. And once people have internet access, engagement did not differ consistently between deprived and more affluent areas. So the difference by deprivation in the previous survey largely reflects access as a main barrier. So we also ask about future preferences. We just need to consider that obviously this survey was carried out between November 2021 and February 2022. So things have moved on since then. But at that time, what we found is that the strongest areas of potential growth were in finding information about health and in requesting appointments or prescriptions. These were activities people already felt comfortable doing online, and they expected to use them even more going forward. In contrast, there was much less interest at the time in receiving clinical care online. So digital tools were welcome for information and admin tasks, but people were more cautious about digital-only models of clinical care. So when we looked at why people reported using digital tools frequently, two factors stood out. So the first one was convenience, being able to access information and services quickly at the time that suit them, and anonymity, which is especially important when searching for sensitive or personal health information. So among those who reported using digital tools infrequently, the main issue was that digital resources simply did not meet their needs. And as well, there were concerns about accuracy of information, privacy, and security of data online. And these concerns were in people who reported frequent use and infrequent use. So it was like the whole population were worried about accuracy of information and privacy. So these are the reports we've done in terms of digital exclusion in Public Health Wales. And then I'm going to talk about our work with WHO Europe. So digital health is at the forefront of the policy landscape in Europe. So it's not only a problem in Wales, it's obviously echoed across Europe. So WHO Europe has developed an ambitious digital health action plan aimed at improving people's health and well-being through the use of digital technologies. We know the COVID-19 pandemic kind of forced services online. Across the region, there is now a growing emphasis on digital health as a key enabler for major health goals. Things like improving access, strengthening prevention, and supporting more sustainable health systems. And also is seen as an enabler of universal access to healthcare, which is very important for the WHO. And also there's a recognition that there's a challenge in terms of health equity in the context of digital health. And so that's where we came in. So when we talk about digital exclusion and equity, it's really important to recognize that inequality doesn't come from a single source. It emerges across three interconnected domains, access, skills, and engagement. So these three domains need to be considered if we want to design digital health systems that are truly equitable, because solving one of them won't close the gap. So access is about having access to connectivity and technology. Skills refers to all those digital skills and ability to use digital technology. And in terms of engagement, it's more related to things like awareness, trust, and perceived benefits. So one of the issues to address digital health equity is that we still lack a deep enough understanding of how inequities shape people's ability to access, use, and engage with digital health. So in response to this, and to inform the Regional Digital Health Action Plan, WHO Europe commissioned Public Health Wales to undertake a scoping review. So the aim was to explore the extent of inequities in digital health across the European region, focusing on access, use, and engagement. And yeah, so this has been published as a report and also has been published as an academic paper. So what we did is we looked at inequities in access, use, and engagement with digital technology, but we mapped them against the Progress Plus framework. So I don't know if you are familiar with it. So Progress Plus is an acronym. So it looks at place of residence, race, ethnicity, culture, language, occupation, gender/sex, religion, education, socioeconomic status, and social capital. And plus, the plus stands for things like age or homelessness and some other factors. So at the end, we included 22 reviews from 2016 to 2022. So although we were looking to specific like the European region, evidence mainly came from the US, then followed by Europe and other developed countries. And we also included some papers from middle income countries or low middle income countries. So we summarize the findings in a heat map showing the direction of effect for each equity domain. So the green cells here indicate a possible direction of effect. Teal cells reflect mixed or unclear evidence, and dark blue cells showed where no data was reported. In terms of access, higher access was observed among white and English-speaking individuals and people without any disability. Evidence for socioeconomic status and social capital was unclear. For place of residence, findings were mixed because results often refer to access to healthcare more broadly, not specifically access to digital health or digital technology, sorry. No evidence was found for occupation, gender or sex, education or age within included studies. In terms of use, more associations appear in this domain. Higher use was seen among urban residents, white and English-speaking individuals, those with higher education, higher socioeconomic status, and younger people. No clear evidence was found for occupation, gender, or sex, social capital, disability, or homelessness. And in terms of engagement, no data was found for place of residence or any of the remaining Progress Plus domains. It was the data we found was very inconsistent, and engagement is considered differently across the literature. And I guess one of the things why we didn't find anything clear in terms of engagement is because we only looked at quantitative data, and normally things like trust and awareness, motivation, trust, all of that comes from qualitative data. So as I mentioned, that was one of the limitations, that we only look at quantitative data, or if they were mixed methods, we only look at quantitative results. We also didn't maybe find a lot of information in terms of sex or gender, because some of the studies didn't disaggregate the findings. So the quality of studies included in those reviews were reported as low. We only found relevant reviews and great literature published in English. And most of the evidence comes from high-income countries as well. And one that is very important that I will come back to later is that there was no intersectionality reported across different types of equity. So there are no intersectionality analysis in the literature, which is an important gap. So from this report, we provided some recommendations for member states. So the first one was to adopt and develop a common framework to define, monitor, and report digital health equity. And the second recommendation is map inequities and improve understanding of intersectionality. As I said, that is a very important gap. The third one is collect evidence on effective approaches and use inclusive and participatory design approaches. Number 4 is develop a good practice approach to the evaluation, design, and reporting. And number 5 is share learning of health and care system addressing equity. And that is also a big gap, because there's no shared learning where others can learn or know what's happening in other countries or in other regions. So the most recent report is another scoping review that we did with WHO Office for Europe. So this was looking at equity considerations across the regulation, implementation, and evaluation of digital health. So this was building on the findings from the previous scoping review, because it became clear that inequities don't only arise in people's access, use, and engagement with digital health. They are also shaped much earlier through the way digital health is designed, regulated, implemented, and designed, regulated, implemented, and evaluated. We wanted to identify gaps and opportunities to strengthen equitable digital health systems. So it hasn't been published yet, but hopefully we will see that published this year. As well, it will be published as a report, but it will also be published as an academic paper. So what was our scope and the framework for equity analysis? So this was a very large scoping review. We included 154 publications. Half were academic, 5 were grey literature. And the period was between 2015 to 2024. We mapped equity across 6 socio-technical components that you can see in this image. 3 are technical and 3 are social. Equity was assessed across 5 domains: demographic, geographic, economic, social, and cultural, and they were informed as well as the Progress Plus framework. But we also looked at SAGR guidelines, which is the Sex and Gender Equity Guidelines, and the UK Equity Act. So the main difference here is that while we, in the previous one, reported sex gender as the same category, for this report, we separated sex and gender. So when looking at those 154 publications, we found that across them, some equity domains were far more commonly addressed than others. So ethnicity, age, disability, and urban-rural residents were the most frequently referenced domains. This appeared in over half of the publications that we reviewed. Other domains such as language or socioeconomic status were less consistently considered. Meanwhile, domains like religion and sexual orientation were rarely included at all. So this uneven attention highlights important blind spots. So digital health research and governance focus heavily on a small set of user characteristics, while others remain largely overlooked. And as I said, in here, gender and sex are separate domains, so they seem like they weren't considered, but if we combine them, they will also be as one of the most commonly ones. And this is very important in terms, for example, for AI-driven technologies, because we know there's an issue in terms of women are underrepresented there, or data sets used to train AI models normally are normally trained overrepresenting men. So that's an issue there. So across the literature, regulatory frameworks for digital health continue to prioritize privacy, safety, and clinical performance, but equity is not yet treated as a mandated regulatory requirement. So, for example, equity is really increasingly considered, but it's often in narrative, but is rarely translated in systematic practice. Some resources, for example, mention that because these digital innovations develop so quickly that the innovations are surpassing regulation, really. So, for example, we found that regulators do not currently require the use of representative data sets, which can lead to inequitable performance, especially in AI-enabled tools. Issues like performance reporting by group, equity monitoring requirements, or bias audits across the life cycle are still lacking in terms of regulation. And then, for example, there are emerging frameworks such as the EU AI Act, which promote fairness and transparency, but health remains largely absent as a distinct domain. In terms of implementation, User-centered design is commonly featured in the literature, but implementation is inconsistent. Co-design and participatory approaches are widely recommended but apply unevenly, despite finding evidence that it leads to more inclusive and relevant digital health tools, particularly for vulnerable populations or marginalized populations. And one thing that we found that I found very interesting is diversity within design and evaluation teams is identified as key for equity. So the involvement of individuals from underserved communities in terms of health professionals developing these innovations to reduce bias and improve relevance. We found that existing assessment processes for digital health technologies do not establish common minimum requirements needed to ensure equity in digital infrastructure for scalable digital health implementation. And implementation often overlooks digital literacy, cultural relevance, and structural barriers to access. So the things that are overlooked are the social factors. So in terms of evaluation, equity is increasingly recognized as important. There are a few new evaluation frameworks like this one, the Digital Healthcare Equity Framework. However, guidance on how these are operationalized in practice remains limited. Evaluation frameworks rarely include standardized equity metrics. Disaggregated data collection is recommended, but these practices are not embedded into regulatory or evaluation frameworks. Although there's more guidance coming up. Intersectionality analysis, as I mentioned before, is rarely conducted in research studies. And digital health technologies require regular performance checkpoints and continuous evaluation. Especially, this is crucial for AI-driven technologies. So, in order to understand how equity could be embedded across digital health systems, it's important. So one of the things we found is equity is increasingly acknowledged in principle, but its regulation, implementation, and evaluation remains fragmented and inconsistent. Terminology for equity relevant populations group is also inconsistent. So for example, sex and gender is sometimes, most of the times, are considered as interchangeable terms, but they aren't, they should be separated. Socio-technical lens shows equity gaps across technical and social components. So inequalities arise not only from the technology in itself, but from the systems, environments, and capabilities that shape its development, implementation, and use. Regulatory implementation and evaluation practices lack alignment, leading to uneven equity integration across the whole European region and beyond. We also included our 154 publications were global, were not only Europe. So the implications for advancing equity in digital health is that equity-driven governance is required to address representation and fairness. Inclusive governance and participatory design is essential for relevance and trust. As I said, diverse development and evaluation teams are key to strengthen relevance and equitable outcomes. Cross-sector partnerships needed to support access, skills, and sustainable inclusion. So for example, here, the third organization sector is very important for those social aspects of digital exclusion. And WHO Europe is well placed to support harmonization and share learning across member states. So here the key message is that fair and inclusive digital health transformation depends on intentionally embedding an equity by design approach across the full digital health lifecycle. So I highlighted this because it has to be an intentional effort and it has to be from the very beginning. So it cannot be an afterthought or an add-on. It has to be considered from the very beginning. So what we, when we talk about a whole system approach, as I mentioned, and addressing equity requires a whole system approach, is the social and the technical aspects of it. If we have a gap somewhere, this gap is cumulative and challenges in any component compound each other and then widen the digital equity gap. So that's why everything has to be coordinated. It has to be a coordinated effort. Some of the key recommendations coming up from this report are to promote the inclusion of equity considerations in regulatory frameworks, strengthen digital skills and digital readiness, and that's not only the public but also the workforce, improve data quality, representativeness, and fairness monitoring, promote participatory governance and co-design with undeserved groups, support wider adoption of equity-driven evaluation and disaggregated reporting, and develop harmonized equity-focused regional frameworks. And I highlighted this because this is something that we will be looking to do in the future with WHO Europe. And this slide is so all our work we've been doing in terms of digital exclusion and digital health equity led to Public Health Wales being designated a WHO collaborating center. So this designation was awarded in September last year, and it lasts for 4 years, and then it can be renewed. So the person who has been leading all this work in Public Health Wales is Alicia Davis, who you can see very small here in the picture. She's the Deputy Director of Research, Data and Digital, and Ian Bell, which is our National Director, is also leading the new WHO Collaborating Center. The vision is towards a future where data and digital health transformation enhances equitable health outcomes, bringing benefits to Wales and the wider European region. The main areas of focus would be inform the development of technical guidance for digital health equity, support activities to strengthen capability for digital health equity, and support efforts to enhance technical cooperation among, as well as awareness raising and advocacy within regional digital health stakeholders for digital health equity. So we will develop a specific annual plan with them and ensuring this co-benefits Wales. So some of our future activities, the number one, that's the framework I was mentioning before. So this, so we are planning to develop a digital health equity self-assessment tool. This will help countries reflect on how well equity is being considered in their digital health programs. Second, we are also hoping to begin shaping a curriculum or learning package focused on digital health equity, and the aim would be to build capability across the system. And third, we expect to contribute equity input into wider WHO strategies and roadmaps. So for example, the image here, documents like this one, like the regional roadmap on AI or tools that support health information system strengthening. So this diagram on the right is an example of the kind of framework where an equity perspective could be eventually integrated in the system. And just to finish talking about our activities. So what we are currently doing is a project that has been funded by the NIHR. It was funded as a development award. And this is led by Public Health Wales, but is in partnership with University of Oxford, Compass, which is a third organization agency in Wales, and public research partner. So we are doing, it's also an evidence review, but it's a very different review, more theoretically driven. And this is to develop an interpretative understanding of how digital exclusion is framed across contemporary literature, including assumptions, theoretical orientations, and links to health or social determinants of health. We are also interviewing stakeholders across the UK to understand how digital inclusion initiatives operate in practice and how their impact is evaluated in relation to health and well-being. We know that the evaluation is a gap there, and there's not a lot of information in terms of health and well-being outcomes. So what we're going to do with this project is we are going to integrate the insights from both strands of the research, and we are going to produce evidence-informed materials to strengthen the design and evaluation of digital inclusion initiatives. These are being co-designed with an advisory panel. Our advisory panel, it includes people who work with digitally excluded communities. We try to look at people who work with, particular groups that are at risk of exclusion, And these materials are meant to be guidance for people working with digital excluded communities. So hopefully this work will help strengthen the evidence base on digital exclusion and health inequalities. Sometimes we feel that digital exclusion is not that well linked with health inequalities. So we want to provide insights to support the development and evaluation of digital inclusion initiatives and foster future collaborative work, particularly in terms of evaluation, where we know there's a gap. And then just to wrap up, what are the key takeaways? So equity by design matters. So it needs to be intentional, as I mentioned. It cannot be an afterthought where digital transformation risks reproducing or widening inequalities. And I think that's one thing that Wales has been very good at, recognizing that equity has to build up from the very start. So digital inclusion is the foundation. We need to look at access, skills, and engagement. Engagement is one that probably needs to be explored a little bit more. So public health Wales is providing the evidence and supporting Welsh government's policy and programs. A systems approach means aligning digital infrastructure with human capability, behavior, and context. So we are taking a socio-technical lens, ensuring our work reflects the realities of how people use digital health. And we believe Public Health Wales is well positioned to bring Welsh learning into European digital health policy and bring European evidence back to Wales. And I think that's everything I have for today.